And thank you to everybody for joining this symposium. It's a great pleasure that we have this opportunity. And you said the next generation should learn from the previous generation. I suppose in some way, I'm the next generation after Hans-Henrik. He was my mentor for decades when I started as a medical student. He's taught me about kidney disease and cardiovascular complications in diabetes. And most of all, how we do clinical science and translate it from good ideas into clinical studies that have impact on clinical care. And I'm sure you're going to hear about how his research in concepts like microalbuminuria that should be established and measured in all patients so we can implement therapy to prevent progression of kidney disease is something you're going to hear about. And this is something that came from, you can say, a concept into today, something we are doing in all patients or should be doing in all patients because it's really transforming care. But without further ado, I'd like to just maybe mention that Hans-Henrik was here at Steno for almost 25 years, both what used to be in Stensens Hospital and Hvidovre Hospital, and then the merged institution. And then he was at Rigshospitalet as a professor at Department of Endocrinology until his recent retirement. And it's a great pleasure to welcome Hans-Henrik, and we will start with the first slide. And I will give the word to Hans-Henrik. Please tell us about complications and how to avoid them in diabetes. And congratulations with the prize. And I was also supposed to give you the indication that please, you can write questions in the chat and then we'll take them after the talk from Hans-Henrik.
So welcome. It's my task this morning to give you the impact of research in relation to prevention and to treatment of diabetic small vessel disease and large vessel disease. Actually, the lecture is reflecting my 50 years in diabetes research, so it's the story of my life you are hearing now. The first slide shows you the Helsinki study, which demonstrates that complication is extremely expensive. In the type 2, it's only 24-fold higher price if you have complication compared to those without. In the type 1 is slightly less. So if you think that science is expensive, then try disease. Hvorfor skifter den ikke? Okay. Diabetic kidney disease is irreversible in humans. That was a statement by Kussmann in 76. We have no case of recovery of cure in the literature. And once the clinical signs of nephropathy, and that means proteinuria, is manifest, you have a relentless progression to death. Please recall that in 76, no treatment was available for this malignant disease. The outlook for diabetic patients with nephropathy was half of them had passed away after 5 to 7 years. After 5 to 7 years, half of the patients have vanished from the earth because of the fact that we have no treatment at all. So what I'm going to tell you about today is actually the evolution during the last 50 years, which have been joyful. Approximately 40% of patients with diabetes will develop nephropathy. Diabetic nephropathy is characterized by persistent proteinuria, elevated blood pressure, drop in kidney function, a very high risk of fatal and non-fatal cardiovascular disease. So it is a malignant disease with the same outlook as metastatic breast cancer. I would also like to warn you that the disease, the first sign of diabetic nephropathy is actually a clinical sign, is fluid retention. And fluid retention is a major player if you want to deal with diabetic kidney disease. So please remember to use diuretics. And most of you forget about it, but maybe you will regain after today. So if you want to detect diabetic nephropathy, you need to pee. However, collective peeing is not recommended. You need to do it individually. However, an early morning spot urine where you measure the albumin creatinine ratio is sufficient for detection of the disease and for monitoring disease. So it's a very simple tool. Despite that, a lot of people is not referred to it, and people still forget to investigate a simple tool. P in the corner, take the samples, measure albumin creatinine ratio, and you can diagnose a deadly disease. This cartoon is quite important. The importance lies in the following. And the bottom line, you can see in green that there's a statement called normalbuminuria. This is the level of normal albumin excretion rate from 0 to 30 milligram per gram. I can point it out. And you can also appreciate that approximately 14% of our patients, unfortunately, will develop progressive rise in albuminuria going into the level called microalbuminuria from 30 to 300 microgram per minute. And about that, we speak about overt nephropathy or macroalbuminuria. The importance of the progression is that when albuminuria goes up, kidney function goes down. In the level of microalbuminuria, the midsection, it is between 1 to 3 ml per minute per year, while in those with overt nephropathy, it's more than 10 ml per minute per year. But another important thing with this cartoon is the dashed line. The dashed line is actually trying to tell you that it is feasible of having patient reversal going from, for instance, microalbuminuria, the mid-level, down to normalbuminuria. Or for that matter, you can even go from higher level down to normal level. The importance of doing that is that you are preserving kidney function, postponing end-stage renal failure, dialysis, transplantation, and prolonging life. So what I'm going to show you this morning is an example of reversal of microalbuminuria. Hey, Bob, do you remember me? We were in the same placebo group. In an attempt to avoid this kind of tragedy, the first study we carried out starting in 1760 was a so-called self-controlled study, meaning that the patient was working as his own control subject. The study was a small study dealing only with 9 type 1 patients with diabetic nephropathy. And at the left-hand side, you have 0, you have -1, -2 years. This is the natural history of diabetic nephropathy. So no treatment specific was given to these patients. We saw a rise in blood pressure of more than 20 millimeters of mercury. We saw a rise in albuminuria from approximately slightly more than 1 gram to 1.5 grams. And at that stage, we started blood pressure lowering treatment. The treatment we used in those days was a beta blocker. We used hydralazine, which is a vasodilator, and we used thiazide diuretics or loop diuretics. And we always had our patient on a diuretic since we knew that fluid and sodium retention is such an important player in patients with nephropathy. By doing that, we was capable of bringing blood pressure down to a level of around 100 as a mean blood pressure, and we kept it down for the following 9 years. What happened to albuminuria? It went down. Instead of having a rise in albuminuria, it actually went down to a level of approximately 0.5 gram of albumin, and we had it at more or less the same level for the following 9 years. The next slide shows the more important part of the game, and that is what happened to the kidney function. So the glomerular filtration rate, which is a measure of the filtration power of the kidney, before treatment was 11 milliliters per minute per year loss, while during the first 3 years of our treatment, it went down to 3.5 ml per minute per year, and went even further down in the following 6 years to around slightly about 1 ml per minute per year. So this kind of treatment, meaning blood pressure lowering with the use of diuretic, was capable of reducing albuminuria, was capable of reducing the loss in kidney function, and the effect was actually persistent, which is quite important. At the same time period, Professor Karl-Erik Mogensen from Aarhus also demonstrated, independent of us, a beneficial effect of blood pressure lowering. And these two small studies actually created a new concept for treating diabetic patients, namely get blood pressure down. And the concept stood the test of time. So even though there was a small number, it turned out that we was lucky enough to find the right tool. 10 years later, in 1993, Ed Lewis and co-workers did the capture study. 409 patients was involved. This, the red was treated with captopril, which is the first ACE inhibitor, and the white one is treated with blood pressure lowering treatment, not involving blocking the renal system. And you can appreciate that the endpoint here is a hard endpoint. It is progression until death, dialysis, or transplant. And consequently, we now have a new treatment modality in diabetes type 1, where we are capable of covering even better than blood pressure lowering in itself, but also by blocking the renal angiotensin system. I would like to stress, you wouldn't believe it, but that's the case. This is the last major trial in type 1. No more. Stop there. And since then, all the power have been run into type 2. Well, I'll show a little later. But before doing that, I would like to mention that one of our co-workers, a wonderful guy called Peter Hovin, did a study looking at the cumulative incidence of diabetic kidney disease during 4 different intervals. All of them 5 years, all of them at Steno, where we enrolled all patients and followed them from the time they have nephropathy until they passed away. And if you start looking at the duration of diabetes after 20 years, all of the 4 cohorts was followed for at least 20 years. In the old days, meaning before antihypertensive treatment was known or used, 30% of our patients after 20 years had developed diabetic kidney disease, and you can see it goes even higher up. While in the time period where antihypertensive treatment was starting to get used, we went down to the lowest number was in the cohort from 79 to 84, and it was down to 12. So this is a wonderful demonstration by Peter Hovin, just to illustrate that blood pressure lowering is powerful. In addition to that, we also noticed that glycemic control played a role, and smoking. And I should recognize my good friend and colleague for many years, Jens Sander Christensen, who was the first in the world to describe the importance of smoking for the development of diabetic kidney disease. Hi, Jens. This other piece of information also coming from our group is from Fie Astrup, and she's now dealing with the cumulative death in patients with nephropathy. And if you start at the left-hand side, this is the data from Joslin Clinic, which tells you that half of the patients at Joslin who have diabetic kidney disease have passed away. At Steno is Torsten Deckert, who demonstrated that 7 years after onset of nephropathy, half of the patients had vanished from Steno. And the 3 other graph is reflecting the impact of blood pressure lowering treatment in different cohorts at Steno. The yellow one is myself. The other one is Peter Rossing. And the last one is Fie Astrup, who actually followed the patient for quite a number of years and could tell you that now the survival have increased to more than 21 years. So going from 5 to 7 to more than 21 years for a malignant disease is pretty good. So that is actually this end of the story dealing with blood pressure lowering treatment in type 1 diabetic patient with nephropathy. I now change gears and go into type 2. And as mentioned already, after type 2 was on the map, people have forgotten about type 1. Type 1 is an orphan. No one is interested in that disease anymore. All of them is focused on type 2, more type 2. And then, of course, that's pitiful. But anyway, in 2001, we had 2 trials back to back, the IDNT study with irbesartan and the Renal study with losartan. I had the luck of participating. The main finding in the study was a 20 and 16% relative risk reduction for the endpoint of doubling of serum creatinine and end-stage renal failure, meaning transplantation, dialysis, or death. So that was a breakthrough for the type 2. Suddenly we have treatment modality which actually worked. So blood pressure down and blocking the renin-angiotensin system. So that was really something. So please look at this time scale. It was 2001, we had Renal and IDNT. During the following many years, until 2019, it's rather close, there was failure and failure and failure. So there was many studies. Sulodexide was using glycosaminoglycans, negative. Astaxanthin was blocking endothelin, was due to safety, meaning heart failure, have to be stopped. On target, used ACE and ARB, didn't work. Treat, where we used erythropoietin, didn't work, was actually causing side effects, meaning stroke. Altitude, which I had the pleasure of working with Frederick to perform more than 8,000 type 2 patients, didn't work. Nephron D, which is the Veteran Administration Hospital, didn't work. Beacon, which is bardoxolone, didn't work. But finally, 2019, we had 2 studies independent of each other with 2 different treatment modalities which worked. SONA is a study where we blocked the endothelial receptor with atrasentan, and Credence is a study where they use glyphosine, meaning a sodium glucose transport inhibitor, and it also works. I would just like to show you the data from these 2 studies. In the SONA study, where we used a blocker of the endothelial receptor, atrasentan, it was actually capable of reducing the recurrence of end-stage renal failure, doubling of serum creatinine with a risk reduction of 35%. So it was pretty good. Unfortunately, that compound was not developed further because the license for the company, which is AbbVie, was running out, and consequently they lost their interest. Think about that. They lost the interest, but it worked for the patient who will not have the benefit because they don't develop it. However, the other something happened here. The other compound, canagliflozin, which is a sodium glucose transport inhibitor, developed, and you can appreciate that those receiving this compound had a better outlook for the combined endpoint of doubling of serum creatinine, end-stage renal failure, and renal death than those without. And this actually you can buy and you can use it every day. Unfortunately, you cannot buy the endothelial receptor antagonist. So now I change again, going back to the level, the midsection, which I call microalbuminuria, the level from 30 to 300 microgram per gram of creatinine. And this slide is called the 3 microalbuminurics. This is Giancarlo Viberti from the Guy's Hospital in London. This is himself. And this is Professor Karl-Erik Mogensen from Aarhus. Giancarlo and myself had the pleasure of describing the importance of microalbuminuria in 82, and Karl-Erik described the importance of microalbuminuria for the type 2 2 years later. So this is a nice picture of the 3 microalbuminurics. In this study, which is a meta-analysis carried out by Nish Chaturvedi, dealing with 700 patients, we are looking at the importance of blocking the renin-angiotensin system in patients who have microalbuminuria and type 1. And we saw a risk reduction of more than 60%. We also saw regression to normalbuminuria. So you remember the dashed line I showed you earlier in the cartoon. You can go from one level to a lower level. And by doing that, you're actually preserving kidney function. And that demonstration was carried out by Elisabeth Mathisen, also at our group, that in a prolonged study of more than 8 years, she demonstrated that we are preserving kidney function in those type 2s with microalbuminuria. This is early studies. Now we are dealing with progression from normalbuminuria to microalbuminuria. So it is the bottom of the cartoon, going from the bottom of the cartoon to the middle of the cartoon. The Croc study was carried out in America and UK. The Steno study was carried out here by Torsten Decker and Torsten Lauritsen. The Steno 2 was also it is not the same as the Steno 2, which I will mention a little later. But the two Steno studies was, of course, carried out here. Henning Bæk Nielsen did the study in Odense. Jens Sander Christen did the study in Aarhus. Oslo did the study in Oslo, and Stockholm did the study in Stockholm. The message from all these small studies carried out and published in the Lancet in 1993 was the following. There was a benefit in prolonging or postponing the development from normalbuminuria to microalbuminuria. So in early stages, glycemic control improvement is actually very efficacious. And that's, of course, a good news. At the same year, in 1993, the DCCT study was published. You'll remember that it was 1,404 patients in the DCCT. At the left-hand side, we have early type 1 diabetes patient with no complications. At the right-hand side, you have type 1 diabetic patient, but with complications. So the finding in the DCCT study, where they used pump treatment and intensified glucose control treatment, they found that there was a reduction in the number of patients developing microalbuminuria compared to those receiving standard treatment. So there was no doubt that it works. But please also remember that even though it works, there was still 15% of the patients who progressed from normalbuminuria to microalbuminuria, despite the fact that they received the best possible treatment, and that was very intensive in the DCCT trial. At the right-hand side, you see the effect in relation to the group 2, those who had microalbuminuria or had lesions, at least when you start off the study. Again, there was a nice benefit of the treatment compared to standard treatment. You should notice, however, that this is slightly cheating, because the scaling here is 0 to 30%. The scaling here is 0 to 50%. So please remember that scaling is not identical, but it doesn't matter. This slide, in my mind, is probably the most powerful slide ever developed in diabetic kidney disease. It's developed by Paula Fioretto and my good friend Michael Maurer. It's dealing with pancreas transplantation, 8 patients involved, all of them receiving a pancreas here at baseline, and at baseline they had a kidney biopsy, and the kidney biopsy revealed a lot of past positive material, meaning Kimmel-Still-Wilson lesions in the kidney. You remember that Kimmel-Still-Wilson described their lesion first time in 36, where Kimmel-Still was flying from the Nazis in Germany and came to America with his biopsy material in the pocket and showed it to Wilson, and then they described the lesion in the kidney, the Kimmel-Still-Wilson nodules, and the diffuse lesion. Anyway, 5 years later, where the pancreas transplant had worked perfectly well, they did a new kidney biopsies in these patients, but still found a lot of the red material which should not be there. The past positive material indicated, yes, there are still lesions. But after 10 years with a normal functional pancreas transplant, they could finally reveal that the amount of past positive material have gone down. Or in other words, this is the first demonstration in human beings that reversibility is feasible in patients who have established diabetic kidney disease. It's a wonderful study. And it also tells you another thing. Even though the kidney looked like a graveyard, it is still a dynamic process, meaning with synthesis and degradation, and synthesis and degradation. And if you can slow down the synthesis and maybe speed up the degradation, you can get rid of it. So Michael Maurer and Paula did a wonderful job. I'll now change to the type 2 who have normalbuminuria. So now we are looking at the importance of blocking the renin-angiotensin system in type 2 who have normalbuminuria, meaning at the bottom of the cartoon going into microalbuminuria in the middle of the cartoon. And you can appreciate that all 5 studies in the type 2 show a benefit. So there can be no doubt that if you have type 2 and you have normalbuminuria, it's a very good idea to block the renin-angiotensin system. The data in type 1 is not conclusive. The studies are few, and the number of patients involved are very few. So you cannot use that. But in the type 2, we have thousands and thousands of patients. It works. This study is called IRMA2, and IRMA2 is an important study from the point of view that we are now trying to treat patients who have microalbuminuria, trying to avoid the occurrence of overt nephropathy. And in the IRMA2 study, we was using irbesartan, which is a receptor blocker of the renin-angiotensin system, and we compared two kind of doses. The 300 milligram in yellow, 150 milligram in green, compared to placebo. The good news is in the top that the 300 milligram dose actually reduced the risk of progressing from microalbuminuria, meaning the midsection of the cartoon, to the large, to a higher section with nearly 70%. The lower dose had an effect, but not to the same extent. So the message from the IRMA2 is irbesartan works, but irbesartan 300 works better than irbesartan 150. So the dosing is important. This data is actually based on the STENO2 study, which I will refer to a little later. All patients in the STENO2 study was yellow. All of them had microalbuminuria. And during the study, and this is reflecting 8 years of multifactorial treatment, some of them was green, meaning reversed to more normal albuminuria. Some of them progressed into the red overt nephropathy. And the impact is on kidney function, and we measure kidney function by using a 51 chromium TA. So in all our studies, we always measured kidney function. We didn't calculate it, we measured it. So it was 2 ml, 4 ml, 5.5 ml. So it has an impact if you can actually reverse the level of albuminuria instead of having it progressing. Now, for the last time, the last part of my talk, I'll be dealing with the STENO2 study. The STENO2 study is a study of 160 type 2 patients who all had persistent microalbuminuria. And the reason for choosing patients with persistent microalbuminuria is the following. They have a very high risk for developing kidney disease and a very high risk for cardiovascular disease. So we are deliberately working with a high-risk population in the study. We used a design called PROBE, and PROBE standing for Prospective Randomized Open Study with Blinded Endpoint Evaluation. So we had the 160 patients randomized either to conventional treatment in red or to intensified treatment in green. Intensified treatment, what does that mean? It means that all patients was receiving blood pressure lowering treatment, blocking the renin-angiotensin system. All patients was receiving lipid lowering treatment using Sartor, 30 milligram once daily. And all patients was receiving intensified glucose control treatment to the best of our capacity. And finally, number 4, all was receiving low dose baby aspirin, trying to avoid thromboembolic episodes. The green curve also received lifestyle information, meaning that we have a dietitian on board, we have nurses on board, we have pedagogues on board, we have a lot of good people on board, and they told the patient to start eating less, lose weight, start exercising, stop smoking, and all the other good things. And what happened? Nothing. In essence, it was complete disaster, meaning the lifestyle intervention was not successful at all. What was successful is to swallow the tablets. That works, and it works every time. So at 4 years, we was evaluating the impact on small vessel disease, 8 years, the impact on cardiovascular disease, and at 13 years, the impact on death. We was lucky enough to get the small vessel disease in the Lancet, and I had 2 publications, one in 2003 and one in 2008, dealing with the impact of large vessel disease and death. So we was quite lucky to get this in a nice journal. This is a picture taken from the time where we had the first publication. It is Olaf Petersen, who is the PI of the STENO2 study. It is a dietitian. It is the two nurses. It's Peter Gede. It's Jakob, a lab technician, and it's Dr. Parving passing by. So that was the gang who actually was running the show of this study. So what was the outcome after 4 years of multifactorial intervention? I need to say that we was capable of lowering blood pressure systolic with 14 millimeters of mercury, diastolic with 7, the lipids with 1.3 millimoles per liter, glycemic controlled by 0.7%. And that was actually more or less the impact of our multifactorial intervention. The good news for the patient is that the number of patients in the need of laser treatment was reduced by nearly 50%. Blindness was reduced, not significant because the confidence interval is hitting the no-gain line. There was very few blind actually. Nephropathy was reduced by more than 50%, and a very nasty complication, which is not taken well care of, is autonomic neuropathy was also reduced by nearly 50%. Autonomic neuropathy is the cause of death in bed. It is sudden death, which actually the patient are suffering from, and usually it's not detected, it's not measured, and the only thing which happened is actually that you get the phone call from the family and said, you know, he passed away in the night, we don't understand it, you just told me he was doing very well. But if you don't check for autonomic neuropathy, you don't know what's going on. Another important finding in the STENO2 study was we looked at the number of patients who developed end-stage renal failure, meaning dialysis transplantation requirement. There was only 1 patient in the group receiving intensified treatment. There were 6 in the other group. I know it's small numbers, but at least it gives you the hint that it is actually feasible by multifactorial intervention to postpone end-stage renal failure in type 2 who are microalbuminuria. So it's actually a pretty important finding. So what happened to death? You have at the top, the red curve is dealing with conventional treatment for half of the patient. In green curve, those receiving intensified treatment here. And you can appreciate that intensified treatment actually had a benefit on death, was actually reducing death by nearly 50%. And I can tell you that this effect was even pronounced or more, it was still at hand after 21 years, where we recently published the data together with Jens Ølgaard and Peter Gede, there was still an effect. However, please look at the start. So if we have done it as the major trials in the type 2 and type 1, usually running for 4 years, the message would have been multifactorial intervention do not work on mortality. There are no impact whatsoever. Forget about it. If you're 8 years, you can also forget about it. You need to wait and wait to see the effect, but it will appear if you are hesitant. Another finding from the study dealing with cardiovascular disease is this is again multifactorial intervention. This is the group receiving conventional treatment, and again there is a huge benefit. The interesting thing with that benefit is it is a benefit on each and all of the components in our endpoint. Mortality in green goes, mortality goes down, MI goes down, stroke goes down, procedures in the heart goes down, revascularization goes down, and amputation goes down. So each and all of the components in our combined endpoint is going down by multifactorial intervention. So it's an extremely powerful tool. Some of you may have heard about heart failure. Some of you may never have heard about heart failure, but heart failure in diabetes is frequent. It's forgotten, and it's fatal. And when I say that, try and look at all the major trials going on in the type 2 nowadays, looking at cardiovascular endpoint. Heart failure is not even mentioned. They're speaking about MI, they're speaking about stroke, they're speaking about mortality, but heart failure, which is the most fatal of all the events, is actually forgotten. So when we looked at heart failure in the STENO study, we observed that we had 24 patients with heart failure, 10 in the group receiving intensified treatment. And by heart failure, I mean heart failure requiring hospitalization. 24 in the group receiving conventional treatment. The curve is coming here. And you can appreciate that the risk reduction for heart failure in the STENO 2 study was nearly 70%. So multifactorial intervention is extremely powerful if you want to avoid a deadly complication to diabetes. So in conclusion then from the the STENO 2 study is that we had a 50% reduction in small vessel disease after 4 years. We have a 50% reduction in large vessel disease after 8 years. We have a 50% reduction in mortality after 13 years. And this effect is still present after 21 years. And the good news is then that a large study also published in the New England Journal of Medicine from Greg is dealing with development in US between 190 until 2010. And the message is that MI is going down with more than 60%, stroke is going down with more than 50%, amputation with more than 50%, end-stage renal failure by more than 23%. In other words, it works. So the take-home message in my mind dealing with multifactorial intervention is do it right, do it right now. Thank you very much.
Thank you very much for this engaged presentation. And if there are any questions, then we welcome them in the chat. We got some applause at least. And then we have a clarification speak Swedish only. Yeah, but any questions, they're most welcome. I think what you have just heard about is really, I mean, it was a change in how patients are treated, where hypertension was seen as the body's protection against damage of the kidney and necessary for actually making the kidneys work. So it was quite brave when antihypertensive therapy was given to these patients actually. And it's amazing that the other day in the outpatient clinic, I actually met one of the patients that were in one of these initial studies. So it's really changed the life of this patient, but also many, many other patients.
You're actually quite right. The notion was that it was dangerous probably to put the blood pressure down because the kidney was living from high pressure and was filtering much more having high pressure. However, the study in animals from Horstetter and Barry Brenner and later on from ourselves here in Copenhagen demonstrated quite clearly that this elevation in renal blood pressure was actually dangerous for the kidney. It was actually killing the kidney. So it was a pretty good idea to get the blood pressure down. You can ask me, why did you start it? Why did you do this study? And the reason why I did the study was actually due to your father. I wrote a thesis on the pathogenesis of diabetic and hypertensive microangiopathy. And I realized during this study, together with Niels Rossing and Niels Lassen, that hypertension and diabetes have many things in common. And one of the things in common was that the passage of proteins through vascular wall was probably not a very good idea. And that was actually the background for me and saying, you know, okay, I learned that. And actually, I can tell you when I had to read or write my thesis, I said to your father, I only write about hypertension. And Niels said to me, no, don't do that. Do both hypertension and diabetes. And oh, why should I do diabetes? You know, it's so boring. And Niels, thank you very much for giving me good advice. And I did both of them and became a diabetologist. Otherwise, I've been a hypertensiologist, and that would be pitiful.
Yeah, Nikolai has a question.
Yeah, so thank you for a beautiful and impactful talk. So that was great. Hans-Henrik, could you try to speculate What would be the future of treating kidney disease in diabetes? Is there any room for further drugs, or are we is the best treatment already available? That's my question. Thank you.
I think actually that we are quite lucky during recent years, because as I mentioned, 2019 actually brought about 2 new treatment modalities, quite different pathways blocked. And furthermore, the year after, we also had the data dealing with the blockage of the aldosterone receptor, meaning what's called it? Yeah, I can't pronounce it. I have a little dry mouth. But anyway, so we have 3 treatment modalities on top of what we know already, which actually works. So I think we are in pretty good shape actually to improve it. But of course, new treatment will pop up, and hopefully one day we will be able to completely prevent the occurrence of diabetes. At least it requires, however, that people is using the information. I think the major fallback just now is not that we need a lot of trials, but we need translation of the trial data into clinical medicine. Peter and I have just made a review of the use of just a simple tool of measuring albuminuria, trying to detect kidney disease. I don't like to mention the data from America. Less than 1 in 4 have it measured. How can you detect the disease when you don't measure it? You can't detect it. And in Denmark, it's much better, but it's not good enough. And I think actually that people taking care of diabetic patients who don't do it should be discussed. They could be sent to Lindholm or some other bloody island because they don't do their homework. And I think it's pitiful actually that we have to fight for do such a thing. It costs nothing. It's not like having a swap stick or whatever. It costs less than 5 Danish crowns.
Then there's a question from Dominic asking about the lifestyle intervention. There has been studies said or mentioned showing that exercise reduces blood pressure. But how was it so disappointing with the effect, or why do you think it was so disappointing with the effect regarding lifestyle intervention in the STENO2 trial?
Yeah, in essence, it was disappointing because we had hoped for that was losing weight, more exercise, stop smoking, not too much drinking, all of these things, you know, the usual garbage. But it turned out not to be the case, despite the fact that we have a very devoted dietitian. We have a very devoted nurses. We have Peter Gede, who's also very devoted. And despite of that, people changing lifestyle, come on. It is very, very difficult. And you can see all the lifestyle, the big lifestyle intervention studies dealing with diabetes. Look ahead. What happened? 0, nothing. Lifestyle intervention is nice to speak about, and it's wonderful for those few who can follow the advice. But I think in essence that the majority need pharmacological treatment. I'm looking at the head of my good friend Jens Holt and think what he have been doing for lifestyle intervention with blocking and using Ozempic. Ozempic is a great compound, you know. If you want to lose weight, you should use Ozempic in a proper dose. Probably for the rest of your life is actually addictive, but anyway, it works. But all the other lifestyle, you know, I think you can speak about it. You can use all the effort to forget about it. It doesn't work. And people are not happy to hear you stop smoking. Stop smoking. They should stop smoking, all of them. That is the most simple advice you can give patient at all. It's one simple advice: stop smoking, and you gain 9 years of your life back. It's not too bad.
Now you recommend people to take tablets, and maybe that brings us to the last question here. What about compliance with this multifactorial intervention? Is that not a stretch when you want to give, or difficult thing when you want to give people many different tablets?
it will always be a discussion of compliance. I think compliance is very important, but I think part of the game is that if the investigator or if the physician is devoted and speak to the patient about what do you think about it? You have to take 7 tablets. So it's not so difficult. You just have to take 7, open your mouth, swallow it, it's over. But if the doctor or the nurse don't speak to the patient about it, they don't do it. But if you speak to them and say, so what about the red one? Oh, the red one, I've forgotten that. The green one, also forgot that. So I think actually that if you are interacting with your patient, you can have a very high degree of compliance, even though it is not a painful disease, because usually painful disease have good compliance because, and you take the tablet. You don't take the tablet, it doesn't hurt you to have diabetes type 2. It just kills you. It's something different. But you have to swallow the tablets. You have to tell them, this is for life. You will never escape it. You have to eat it for the rest of your life. But if you do that, you can live for a prolonged period. It reminds me of a funny story. You will have that dealing with this recent vaccination for this, you know what it is. And there was an old guy, one of the first who got the vaccination, and the nurse who gave him the vaccination said to him, so now you can be 100 years. And the guy looked at her, I'm 101 year already. So, yeah.
Thank you very much. I think on that note, we have completed the questions. Torben says congratulations, and people appreciate your engagement, and I think that's what works when you talk about adherence to medication. So thank you very much from us, and back to you, Nikolaj.